Thank you very much, Dr. Fleshner and Dr. Fezzi Ramsey for the invitation to participate to this panel. It's really with pleasure that I'm here and to talk about stricturoplasties and the role that stricturoplasties have in the armamentarium of an IBD surgeon when dealing with patients with Crohn's disease. And I think that stricturoplasties, rightly so, are one of the most exciting fields in surgery for inflammatory bowel disease, and I'm here to demonstrate that to you and specifically to talk about where the stricturoplasty really fit in the surgical treatment of a patient with Crohn's disease. Before I do that, I just want to remind you of what we know about Crohn's recurrences when they come to surgery. I'd like then to go over the stricturoplasty techniques and specifically the classifications, the complications, the indications, contraindications, and the influence on recurrent disease, which I think is an important topic to understand. And then if we have a couple of minutes, I'll even talk about future concepts on the use of stricturoplasties. Now, I am not here to tell you that Crohn's disease is a recurrent disease. You know that very well. But I'd like to review with you 3 fundamental papers of the past 20 years that have clearly delineated to us how recurrent disease occurs and how it looks. The first one was published by Steve Hanauer and Dance out of the University of Chicago in 1995 by comparing radiological images of the index Crohn's with radiological images of the recurring Crohn's in the same patient. They found a correlation which was practically 1-to-1 between the extent of the index disease with the extent of the recurrence. So in other terms, if the original disease, say, was a 15-centimeter terminal ileal disease, there was a 95% correlation with recurrent disease being 15 centimeters in the neoterminal ileum years later when the recurrence was ready for surgery. The second paper came also out of the University of Chicago and was by Dr. Ficera and myself, and this is a busy slide, but we had the opportunity to operate on the index disease in 79 patients and then operate on the first recurrence of these 79 patients. And so through very accurate note-taking, we're able to clarify where recurrences occurred. And again, I said the slide is busy, but the message is that in about 75% of situations, the recurrences occur at the ileocolic anastomosis or on the immediate pre-anastomotic neoterminal ileum. And the final paper I want to share with you is the paper by Simillis, published in the American Journal of Gastroenterology in 2008. This was a meta-analysis where Simillis accumulated and collected some 2,500 patients, divided them in 2 major groups of penetrating and non-penetrating phenotype. And the first recurrence was in 75% of the penetrating phenotype was a penetrating phenotypic recurrence. And in a non-penetrating group, 75% also had a recurrence, which was non-penetrating. So by taking the data from these 3 seminal papers, we now know that recurrences after an ileocolic resections occur at the anastomosis or in the immediate pre-anastomotic neoterminal ileum. The length of the recurrence is going to be practically the same as the length of the index procedure. And the phenotypic recurrence in 3/4 of cases is similar to the phenotypic index procedure. Now, this is important when you talk about recurrence diseases, because if you do have a patient that has an extensive Crohn's disease and requires a resection, you can bet that that patient will come back with a recurrence which is as extensive. And additional surgical procedures and additional resections will soon create a short gut syndrome. Hence, the stricturoplasties that came out as an alternative to resections and to maximize preservation of intestinal length. And we should pay tribute to Emmanuel Lee in this picture, colorectal surgeons in Oxford, used to practice at the old Radcliffe Infirmary. And these are pictures from his charts. You can see a Haneke hemichoric stricturoplasty and a Jaboulet stricturoplasty. Both pictures are courtesy of Neil Mortensen, who kindly gave them to me. Now, the stricturoplasties nowadays are categorized in three groups: conventional stricturoplasties, such as the Haneke hemichoric procedures, the intermediate procedures, such as the Finney stricturoplasties, and the complex procedures, such as the side-to-side isoperistaltic stricturoplasty. I will not go into too many technical details, but I just want to show to you when we use these stricturoplasties. And there is no question that the most commonly used is the Haneke hemichoric stricturoplasty. I'm sure that all my colleagues here would agree that as many as 85% of all stricturoplasties that we do are Haneke hemichorics. They're really well suited to short strictures, about 5 centimeters, 7 centimeters at the very most. And the stricturoplasty is done by creating a longitudinal enterotomy on the antimesenteric side of the small bowel, closing it into a transverse fashion and creating, therefore, some kind of a diamond-shaped deformity that really enlarges the internal lumen. This is a Haneke hemichoric stricturoplasty, and as I said, is the most common stricturoplasty performed. The Finney stricturoplasty is probably performed in about 5 to 10% of cases. It is well suited to strictures which are a little longer, maybe 7, 8, 10 centimeters. And it is done by folding the small bowel on itself and creating an anastomosis between the two limbs, as it is demonstrated here in the cartoon. Trying to do a Finney stricturoplasty in longer strictures is really not well advised, because all we're creating is a side diverticulum in the small bowel, which can act as a receptacle to enteric contents and therefore be complicated, the source of complications such as bacterial overgrowth and septic complications. Neither the Haneke hemichoric stricturoplasty or the Finney stricturoplasty are really well suited for extensive small bowel disease, such as the one that is depicted here, where for 2, 3, 4, 5 feet of bowel you have a stricture followed by a dilatation, another stricture followed by a dilatation, another stricture followed by a dilatation, and so on and so on and so on. Surgically, from a technical point of view, it would be very easy to do a small bowel resection. It would probably take no longer than 45 minutes. The patient will go home in 2, 3 days. But this approach is not cognizant of those papers that I showed you before, and that's why I share those papers with you, where we know from the paper from Hanauer 1995 that recurrences will come back with the same kind of extent. And so you can understand that if we resect 3, 4 feet of mid-bowel, jejunum and ileum, and then years later the patient come back with another 3, 4 feet, and then a year later come with another 3, 4 feet of recurrence, soon this patient will have a short gut. So in 1993, I came up with the idea of the side-to-side stricturoplasty. I performed a few before publishing. The first paper that I published was in 1996. And the side-to-side stricturoplasty is a very simple concept. Taking a long segment of intestine with strictures, the intestine is divided in half. The two ends, the two loops of intestine are put one against each other, and a very long enteroenterostomy is performed, creating therefore a large lumen out of two lumens which may be compromised. And with the experience in stricturoplasties nowadays, surgeons who deal with a lot of patients with Crohn's disease frequently perform multiple stricturoplasties on the same patient. And nowadays, the use of stricturoplasties has been extended to other intestinal territories, which initially we did not conceive about, such as the duodenum. In this particular case, this is a stricture at the inferior genu of the duodenum. as demonstrated by that barium enema with actually reflux, as you can see in the pancreatic duct up here. And here is the stricture. And this is the same patient oriented in the same way. You can see the stricture here. This is the head of the pancreas. And a longitudinal enterotomy can be performed. Duodenotomy can be performed, and after identify the ampulla, that can be closed in a transverse direction. Therefore, doing a stricturoplasty in the duodenum rather than the traditional gastroenteric anastomosis bypass. Now, stricturoplasties complications, fortunately, are within reasonable limits. This meta-analysis by Campbell, published in 2012 in DCR. Campbell gathered 32 studies with some 1,600 patients and 4,500 stricturoplasties, and looked at complications early and late, stratified the patients by the stricturoplasty type, the conventional, the Haneke, Mikulicz, or Finney, the non-conventional, the Michelasi, or modifications of the same. And we were very gratified to see that even a non-conventional stricturoplasty had a very low early and late complication rate. So to summarize, when to do stricturoplasties? Well, these are the indications: duodenal, jejunal, neoterminal disease with single or multiple fibrotic strictures, and recurrences on previous small bowel and ileocolonic anastomosis. Probably even more important is to figure out when not to do stricturoplasty. So what are the contraindications? And I list the inflammatory masses, phlegmonous masses. Generalized intra-abdominal sepsis is obviously a contraindication. Long strictures with a very thick, unyielding intestinal wall, in my opinion, are a contraindication. Obviously, the presence of dysplasia or carcinoma is a contraindication to a stricturoplasty. That patient needs to have a resection. If the patient comes to surgery for hemorrhage, chronic hemorrhage, I don't believe that those patients really benefit from stricturoplasties. Those patients probably are better served with a resection. And obviously, a stricture close to an area that you're going to resect, it is in the economy of the surgical procedure to also resect that particular stricture together with the area that you're planning to resect. Now, let me talk about the recurrences on stricturoplasties, because this is probably the most exciting area, in my opinion, in Crohn's disease. Now, we have known for a long time that stricturoplasties have a low recurrence rate. And if you look at data from these 6 papers, they were all published in the late 90s and early 2000s, with all of these papers had at least 100 stricturoplasty patients, and which had been followed for at least 3 to 7 years. There was a 33% recurrence rate of Crohn's in these particular patients, but when the authors went and looked at the recurrence on the stricturoplasty site, it varied between 0 and 8%. And this message was driven probably in a better way, a more clear way, by a paper by Yamamoto, published in 2007. And this paper, he collected some 19 papers on stricturoplasties. It was a meta-analysis. And there was more than 1,100 patients with more than 3,200 stricturoplasties performed. And although the overall recurrence was what you would expect, when these papers analyzed where the recurrence occurred in 90% on new sites away from the stricturoplasty site, and only in 10% on stricturoplasty site. And in consideration that there was an average of 3 stricturoplasties per patient, Yamamoto calculated a stricturoplasty site specific recurrence of 3%, which is much, much less than what you would expect after a resection and an anastomosis. So almost suggesting that a stricturoplasty has a protective effect on on recurrence from Crohn's disease. Now, in 2000, we had that suspicion because after having done many site-to-site stricturoplasties, wherever possible, we were doing endoscopies and we're taking biopsies at the level, at the site of the side-to-side stricturoplasty. And this is actually, I have to recognize Russ Cohen. He did this particular endoscopy on this particular patient. This was a patient that had extensive proximal jejunal disease, where I'd done a side-to-side stricturoplasty, but also had duodenal disease, for which I had to do a gastrojejunostomy. And Russ very aptly put the gastroscope into the stomach, and then through the gastrojejunostomy, and a foot later we were a side-to-side stricturoplasty. We took biopsies, and as you can see endoscopically and pathologically, the disease has quiesced. The disease has melted away. And we published this in 2000, and a paper that will be published in JAMA Surgery at the end of this month by Marilena Fasi confirms these observations. They had a study period of 1996 to 2010 with 91 patients where they did side-to-side stricturoplasties, and 22 of them, the side-to-side stricturoplasty was on the neoterminal ileum, so it was easy with colonoscopy to check on this side-to-side stricturoplasties, and they had endoscopic follow-up for more than 5 years. And out of those 22 patients, 6 had recurrent disease, but the remaining 16 were found to only have minimal residual erythema of the mucosa up to 5 years, supporting our initial observation that the index disease goes into remission after a side-to-side stricturoplasty. So there is an accumulation of data to suggest that stricturoplasties have a protective effect against recurrence. And so not only they're bowel sparing, but now we know that most likely they induce disease remission. Wouldn't it be nice if they could also help in return of function? And this has not been demonstrated yet, but in my opinion, that's where the excitement resides in stricturoplasty. And so if you push the argument a little bit, and follow me for a second, could stricturoplasty techniques be used for stricturing terminal ileitis? I know exactly what you're saying right now. You must be out of your mind, because if I present you with this CT enterography, and if you present me with this CT enterography, I'm going to say this patient requires an ileocecectomy. Ileocectomy is standard of care for this particular terminal ileitis. But let's just think for a bit. What about if we were able to do a side-to-side stricturoplasty on terminal ileal disease? In consideration that now we know that disease regresses after a side-to-side stricturoplasty. Can it be done technically, first of all? And yes, it can be done technically. And under IRB study, I've already done several of this side-to-side stricturoplasties on terminal ileitis. And interesting enough, 6 months later at colonoscopy, the disease seems to have disappeared, or at least quiesced quite a bit and regressed. So I'm not here to tell you that terminal ileitis nowadays must be treated with a side-to-side stricturoplasty. Far from what I said. Terminal ileitis in December 2015 is still treated, standard of treatment, with an ileocectomy. But if we want to push the boundaries of what surgery can offer, and if we want to understand how Crohn's recurrences occur and what happens after surgery, this is an area that needs to be studied. Thank you very much for your attention.